Okay, good morning, everybody. My name is Morgan Bessie. Again, I am a family nurse practitioner. I work in primary care. I do a lot in the obesity medicine world, as well as women's healthcare. It's something I'm really passionate about. I am so excited to get started today. Some really, really cool things happening at Archer. If you haven't heard, we are now accredited through ANCC, and what that means is we can now offer continuing education hours for everything that we do. So, with that being said, starting I think today, we can offer continuing ed, but you have to be logged in through the Zoom account. So if you're watching from like Facebook or Instagram, unfortunately, we can't offer that because we have to be able to verify through the Zoom contact. So next time that you log in with us, please, please, please log in um, through your Zoom accounts, and we can go ahead and offer continuing ed, which is super, super exciting. So all of this time, everything that you're putting forth to just bettering your career and your knowledge is doesn't go unnoticed from us. Okay. Give me just one moment. Okay, it looks like we are up and running, which is great. Just want to make sure everything's going well and that you can hear me. Okay, so a couple of things. We have what's called the SurePass Pro. This is really great. When we encourage people to go ahead, click on this QR code and check and see if this is something that would help you. I think it's absolutely critical that you feel really, really well prepared when you're getting ready to go sit for your boards exam. And what the SurePass Pro does is essentially allows you to feel that 100% confidence. And we encourage you to use what we consider to be the Sure Pass method. And what that means is to watch the topic videos, watch the on-demand videos, come to our live review sessions, and watch all of our mentoring and webinars that we offer. But then go ahead, in addition to that, be doing about 25 to 50 exam questions every single day. All right. You're no longer waiting for life to happen when you are waiting for the bus or when you're maybe at a laundromat or something. Pull out your phone and go through on our on demand questions and Q banks, and you can be continually just, practicing with the way that those exam questions are formatted. And then the content part, the on-demand part, is going to really bolster up all of your kind of basis of the education that you have learned. And it's just really going to work well together. We also offer 1 hour of mentoring with that pass, which is just a really great way to create a study plan, really, is what we help people with. There, then any sticky topics, we can go ahead and delve into those a little bit more. So all really, really great. And then you're going to take an exam. And we recommend doing at least 4 weeks of prep and 4 exams as a minimum to really understand that how that exam works to tell you if you're ready. And if you take it just once and it tells you you're ready, that's not really that great of a data score because the next time you take it, it might put you in the low to intermediate range for your readiness assessments. So we really encourage people to go ahead, watch topic videos, 25 to 50 questions a day, perform at least one assessment every week, and for a minimum of about 4 weeks, and then you should be ready. And that meter, we have a meter that will tell you your probability of passing. And so it goes from low to high chance of passing. And we know that if we do it at least 4 different times over the course of over the course of 4 weeks, that it's going to give you the most likely probability and the best predictor for how you're going to do for your exam. Okay. Again, we are so excited to give you guys some hours for continuing ed, some contact hours. So go ahead and if you're through the Zoom, we can do it through Zoom. If you're on Instagram, if you're on Facebook, unfortunately, we don't have that ability because we can't keep track of how long you watch for. So the next webinar, I suggest that you get the Zoom pass Zoom in order to go ahead and write those contact hours. It is so important. I am renewing my ANCC credentialing this year and trying to find and keep track of all of your continuing ed hours, super, super important. And you will get certificates. I suggest getting a file, saving it in the cloud, and keeping track of all of your continuing ed because in 5 years, when it's time to renew, you're going to have to be able to provide those hours. And it's so much easier. Maybe even a spreadsheet is what I'm going to do for my next 5 years is create a spreadsheet to be able to just super easily calculate and keep track of all the continuing ed. So super exciting thing that we're doing here. And we're looking at possibly moving into that realm of being able to offer you guys continuing education for all of the work that you do coming and listening to us. All right, so for today, our objectives really are we're gonna go over a brief anatomy of the abdomen. We're gonna explain how to assess and manage certain common gastrointestinal conditions and be able to feel really confident with your diagnosis and management of those conditions moving forward. Okay. Um, so again, here's our SurePass thing. Please connect with us online in our community. And then next up today, I feel like we're talking about a lot of different things today, but we're going to review GI, and I like having a lot of different ways that we can interact. And this helps your learning. It's completely anonymous, but what you can do is pull out your phone and scan the QR code. And if you are using your phone to join me, you can go ahead and open another tab and go to slido.com/GI review for NPs. And that should connect you to be able to see everything here. Oh, and it looks like we had somebody raise their hand. Is everything going okay here? Patricia, did you have a question? You can put it in the chat for me or in the Q&A before we dive in. Can everybody hear me okay? We're good. Technology is working. We are streaming all over the place this morning. So just want to make sure that we are in a spot where everybody can hear and we are good to go. Okay, so I'm going to go ahead and do this. Awesome. People are already on it. So scan this QR code and let me know where you're joining from. We have somebody from West Virginia, Louisiana, Ohio. Yes. I'm from Colorado. I'm in Colorado. It's a pretty sunny day and there's a lot of snow in the mountains. I'm a big skier, so that makes me excited. I love getting up to the Rockies pretty much every weekend, every Sunday. Houston, Florida. Awesome, you guys. Great. And I'm just happy. I want you to participate with me today, okay? That's how we learn. I learn from you, you learn from me, and we learn from each other. This is just what we want this environment to be. It makes it more fun too. Okay, and then who are we today? Do we have associate degree in nursing, RNs with the BSN, LPN, students? All right, we got some NP students, some others, nurse practitioners. Awesome. Okay, so that current nurse practitioner, go ahead, get these contact hours for today. All right, BSN. Awesome. You guys are great. I wonder what that is. I'm curious. Who else we have? I need to make it so that you can just type in what you do. Super cool. Okay. Before we get started, does anybody have any pressing questions, anything you're really hoping that we covered today? If you do, you can put it in the chat here. Q&A. Okay, we will get a certificate after completion. Yes. Let me go back real quick. And this is the first time we're offering this, you guys, and I'm not 100% certain. Um, how we get to do this. Let me go back to that slide. Okay. Um, so you have to be in the Zoom course for at least 80% of the time. Um, and why don't you email here? Okay. Why don't you email us here asking about that certificate? Okay. It might just auto-populate. I'm not certain how it works. We just learned about it yesterday. And so this is the first time that we'll be offering it. But yes, that's our goal is to be able to offer 1 hour per per lecture that you listen to through these free on demand. So that's amazing. There is not very much free CE out there. So definitely tune in, get on our email list if you're not, so that you can really get into those. Okay. We are going to jump into gastroenterology today, okay? We're going to cover, like I said, just the abdominal organs and their functions. We'll talk about GERD. We'll also discuss the common symptoms and causes, symptoms, and then the treatment. We're going to go into peptic ulcer disease. We're also going to talk about common GI infections like gastroenteritis, pancreatitis, diverticulitis, appendicitis. We're going to breeze over some of those special skills that we need to know and those techniques in order to diagnose these things. We'll differentiate between IBS and IBD. And then we're going to go into a case study. So I am so excited. Let's get started. One moment. It looks like I have some questions in the Q&A. I'm going to see if these are pressing. Oh, you did a different lecture. It will be emailed to you after this concludes if you are logged in with your email. Okay, thank you so much, whoever let us know that. So great. This is so good. I'm really excited that we get to offer this. Again, anybody who's tuning in from Instagram or any of these other places, let us know. And next time, tune in via Zoom so that we can get you those credits, okay? We can't unfortunately do it through any of the other streaming platforms. Okay, before we tackle the exam, let's just do a quick refresh of our abdominal anatomy. Okay, so we have here is just one look here, and we go ahead and we actually divide the abdomen into four quadrants. Okay, I just want you to take a quick look here. We have our liver, our gallbladder. Our kidney lays right behind that. We have our spleen right behind the stomach here. We have the greater omentum, which kind of covers everything, supplies lots of blood, nerve, all of that to our the vascular system, the nerve innervation system to our intestines. Very, very important. We have the stomach, we have our pancreas, and then we have our colon. Small intestines live right under all of this, the omentum, but we have ascending, transverse, descending colon that feeds into the sigmoid colon, finally into the rectum. That's where we go. I have another look here when we divide it into our four quadrants. We have that right upper quadrant, left upper quadrant, right lower quadrant, and left lower. This is just a map. This tells us, and we use the quadrants to describe our findings accurately. Okay. So in our right upper quadrant, what we see here is the liver and the gallbladder. These guys are responsible for processing toxins and fats, and it uses that stomach nearby that handles the food of digestion. The small intestine, that guy's going to expand from the upper quadrants down into the right lower quadrants. And its responsibility really is to absorb those nutrients before handing off to the large intestine, right? And then we have in those upper quadrants, we have that pancreas, which is really helping us regulate blood sugar. Also, the spleen, which is, we think, really important in immunity. And that's those guys both in that left upper quadrant. And then we go to the lower quadrants here. We have the sigmoid colon in the left lower quadrant that moves stool. That's going to be an important thing when we think about pain down in that left lower quadrant. So something we always want to consider what's going on with that guy. And then in that right lower quadrant, we specifically think of one little guy, which is the appendix, right? So anybody comes in, they have right lower quadrant pain. It can be a multitude of things, but what we want to rule out is anything that's acute and very concerning, like an acute abdomen or an appendicitis. We have him right here. And what the function is, we're really exploring the idea that has to do with some immunity functions. However, people tend to do pretty good without it. So we do see those removed in the event of an acute appendicitis. All right. When we're thinking overall about the GI exam, we have to break it down just a little bit about how we perform it. And this is an important question to review for the boards because they're going to ask you specifically, how do you perform an abdominal exam and why do we do it in this order versus other orders of other types of exams? And so what we're really going to look at is inspection, then auscultation, percussion, which is a little bit different than anything else we do, and then finally palpation. So So the last thing we really do is put our hands on a patient when we're concerned around the abdomen. And we specifically follow this order to avoid disrupting bowel sounds. So our bowel sounds are really, really important. So when we're doing an abdominal exam, we're really going to make sure that our patient is comfortable, right? We're going to have them lying in a supine position. Sometimes we'll have their knees flexed. To make them feel a little bit more comfortable, decrease the guarding that might occur just because we don't love to have our abdomen touched, and a lot of people are ticklish. So we're going to kind of figure out how to do that best. Make sure you warm up your hands first. And what you're going to first start with is looking at the abdomen. You can look from above, and then you're going to look from this side, and you're looking for any sort of abnormal shapes. Are there any masses? Is there any dysregulation? Is there a protrusion happening here? Is there movement that we can see? Can we see that pulse kind of rising and falling in their aorta, which would be a normal finding? Are there skin changes here? Is there inflammation? All right, that's what we're looking for. Next, we're going to use our stethoscope to auscultate bowel sounds in each of those quadrants. Normal sounds are low pitched, it's that gurgling stomach sounds. We want to hear 2 to 5 sounds per minute. And if we hear more than that, we consider that hyperactive. And if we hear less than that, we think of that as hypoactive. And if we have no bowel sounds at all in a quadrant, that would be considered absent. And when we think of absent bowel sounds, this is a serious GI condition going on. Our bowels should be moving despite when we last ate. They will move more or less depending on when meals are going and being processed through there. However, if there's no sounds whatsoever, this is something more serious. This should alert you to take some action right away. All right, after listening, we move on to percussion. I tend to use my middle finger. I ensuring that I'm not touching the rest of the abdomen with any of my other parts of my hand because that will dampen the sounds and will kind of ruin your percussion. But you put your middle finger down. I use my other middle finger to tap it, and then I'm going to move through all of the quadrants. Okay. And this is an important thing that we do, and it takes time. You can practice right now on your desk, and you can just get that tap, tap, tap sound. I encourage people to do this on different things. You can do it on walls. If you do it over a wall and you feel where you hit a stud, you will actually know that this is the difference. And this is just training your ears to understand how those subtle sound changes actually do indicate something different. Okay, so what does it indicate? Tympany, that's going to indicate that we have some air-filled structures like an intestine underneath it. But when we hear dullness, so when we go over something solid, like when we go over a stud in a wall, versus that hollow area when we hit the stud, just like when we hit the liver per se, we're going to hear a dullness. If we go over a mass that shouldn't be there, we're going to hear some dullness occur. I also hear dullness when I'm palpating or percussing over something like a stool. Like if we have a bolus of stool in that lower intestine, we will be able to hear timpani, 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 and we get down to where there's a massive stool, and we're going to hear the change in that sound. Practice on your partners, practice on your children, practice on yourself. Get used to hearing those sounds because they are important, and this can be just one more tool in your diagnostic assessment for a patient who's coming in with some sort of abdominal complaint. All right. When I feel like it's a lost art, I'm going to say that. Um, I don't know that it's emphasized too much in our training, but it is an art that we have at our side when we don't necessarily have something like an ultrasound or a CT scan readily available. This just gives us one more little clue, okay? Non-diagnostic, but a clue. All right. Finally, palpation. Like I said, warm up your hands so they're not super cold. Don't be afraid to have the patient lift up their shirt. And I always kind of start with their hand first and let them know what I'm going to do. If somebody has an acute abdomen issue, some sort of, let's say, an appendicitis, the moment you get near them, they are going to start getting a little bit nervous about that touch. They have a pain going on inside them that tells them, I don't want to make this worse. And so what they're going to do is what we call guarding, and they start to kind of tense up a little bit and they're really worried about you touching. That is different than somebody who is ticklish. And you need to kind of understand that and talk through with your patients to understand those differences and what is guarding versus somebody who is just very ticklish or just very modest and not liking to be touched. Okay, so I always ask for permission, move slowly, use their hands to guide as they kind of get used to what it is that I will be doing. And we start with light palpation, and then we're going to go in for the deeper palpation. And we're looking for masses. This, again, it is important. I had one patient who came in. We found a fairly large mass. Turns out she had breast cancer, which we knew about, but had a metastasis in her abdomen that we could actually palpate during her annual exam. So, again, this is a little bit of a lost art, but it has a lot of value. We also palpate the aorta, and what we're looking for is any sort of aneurysm. Are you feeling the pulse beyond what we should be? So again, practice, practice, practice. Get your baseline normal of what things should feel, look like, sound like, what that tympani, what's the difference between tympani and dullness? Because when somebody comes in and they have an issue, the more normal that you have, the better you're going to do with an abnormal. You're going to say, that I don't know maybe what it is, but that is not normal. Maybe you don't say that to your patient, but that's what you think. Okay. All right. So we talked a little bit about this order that we do things. Again, critical that you know the order for your exam because you don't want to disrupt bowel sounds because once we touch them, they might start gurgling and we have now missed an absent bowel sound. Okay. Or we took something from hypoactive and we put them into a hyperactive state because they tend to respond to a little bit of massage. All right. So inspection, auscultation, percussion, and finally palpation. All right. My favorite. I feel like this is such a common complaint. I do work in primary care. I have so many people coming in complaining of acid reflux. So, what is it? We have gastric contents that is coming up, sneaking out of that lower esophageal sphincter, right? That sphincter that connects the esophagus to the stomach. And it is, for some reason, relaxing inappropriately and allowing gastric contents to flow in the reverse direction. And when we have gastric contents flowing back up, our esophagus does not have the same tissue protection mucosal layers to protect from the contents that is created, that hydrochloric acid that's created in the stomach, and it causes a lot of irritation in that esophagus. All right, so what do we think about? There are a lot of risk factors. We have modifiable risk factors and we have non-modifiable risk factors. As a nurse practitioner, it is your duty to address anything that we can change, right? But what we think about age, that is a non-modifiable risk factor. We can't change somebody's age. But if they're overweight, if they're smoking, if they're pregnant, if they're using a lot of NSAIDs, diet, alcohol, caffeine, all of those things we need to be asking about and figuring out how can we motivate our patients to make those changes to see if we can simply improve their symptoms by just changing some lifestyle things. All right. I'm like I said, I'm really, really interested in obesity medicine. I've been studying a lot around that. We have different types of medications that we can use. I suggest if somebody has a history of acid reflux GERD, that it's something that you have a conversation with and get comfortable with when we're addressing folks that do suffer from obesity, which is a chronic disease. All right. Our most classic symptoms associated with GERD is that heartburn. Okay. It can be asymptomatic. Okay. I did have a patient who came into me and said, listen, the dentist told me I need to get on a PPI because I have dental erosion. And I was like, interesting. Do you have any symptoms? No, none at all. But significant amount of acid coming up to the point that it's eroding the dent, his teeth. And so that would be considered asymptomatic regurgitation, which does exist and to know about. But typically, most people will have symptoms. Those symptoms can look different, just kind of a raspy, dry cough, like a nagging cough. As that throat is getting irritated, we go to sleep all night. Maybe the burning doesn't bother us too much, but we wake up and we have this kind of chronic cough hoarseness. It can induce a little bit of worse than asthma. It wouldn't cause asthma, but it can kind of present similarly. Might have a sore throat, might feel like something stuck in the throat, and then this really big pressure. And what is one thing we want to rule out if somebody's coming in for symptoms like GERD? What can present similarly? You can share this in the chat with me. Um, is the chat? Let me just make sure it's not. Okay, yeah, it looks like it should. When we're thinking about GERD, what is one thing that we absolutely always have to rule out and have in the back of our minds when somebody's talking about that? I think I have acid reflux. What are some questions? What are some things that you might be concerned about in addition that you want to make sure I do not miss? And if you can, put it in the chat here. Let me see if this is working. This is a test. Can you all get in there? What is a cannot, do not miss on an assessment with somebody with GERD? All right, I'm guessing maybe this chat is not working, which is totally fine. We'll just um, keep on moving. What I'm thinking about specifically is an MI, and you're probably all sitting there saying, MI, MI, MI. Yes, that is what it is. We cannot miss a heart attack, all right? We cannot miss angina or chest pain or anything like that in these events. So, really critical that we're asking about those. Um, Oh, ulcers, good. Yes, absolutely. Another really great thing to think about. So, when we think about some red flag signs or symptoms in relation to GERD, so we think there's GERD, if there's difficulty or painful swallowing, or if they're feeling really full really fast, I would go ahead and refer those guys out for an EGD. Let's figure out what's going on. Um, when we're doing an exam on a patient with GERD, typically they don't have a lot of symptoms that we can recreate right then and there. Okay. Um, we think a lot about potentially a little bit of epigastric pain, but that's about it. Um, so we want to make sure that we are just constantly, oh, I have one more question. Okay, good. We want to make sure that we're just constantly kind of assessing for those red flag signs or symptoms, and that we are feeling totally confident of what it is that we're diagnosing. Okay. Um, then let's see here. Moving on here, we're going to just talk a little bit about treatment. So, we talked about those modifiable risk factors, right? Helping patients really figure out how can we best lose weight? Does it look like a GLP-1 treatment? Is it simply just diet and exercise? And we can try that for a little bit. How does that look? What have they tried? Smoking cessation. If they're a smoker, let's get that under control. Do we know certain trigger foods that just seem to make it worse? Eating earlier in the day, all of those things can be beneficial. All right. Typically, if a patient is coming to you, they might have already tried a lot of those, except maybe smoking and weight loss. So then we think about pharmacologics that we have at our ready that we can prescribe for our patients. We have a few things that we consider. So I always give patients a trial of lifestyle if they haven't already. And I think like doing a little piece of education can be good. And I also do it to shared decision making, right? Have you tried this already? Are you looking for a prescription, right? It's kind of this conversation that you have to have, maybe not quite so candid, but really asking what is it that they've already done and where we can go, and how aggressive we need to treat, how worried are we based on their symptoms, and again ruling out an MI, making sure there's no reproducible pain with like exertion or something like that. Okay. Um, H2 blockers are really, really great. I use these a lot. We think of famotidine, cimetidine to be the most. Ranitidine used to be there, but we've taken it off the market because of a risk of cancer. But what these guys do is they reduce stomach acid by production of the hydrochloric acid by blocking histamine receptors on H2, specifically H2 receptors in the stomach. They work typically pretty quickly in about 15 to 30 minutes. However, they're effect isn't long lasting. Okay. What do we think about when we're thinking about histamine blockers? There's another medication that we commonly use, or let's say indication for histamine blockers. And what can some of those do? Um, if anybody just kind of think, you can say it to yourself. Um, but specifically, when I'm thinking about antihistamines, I'm thinking specifically about something like Benadryl. And Benadryl can have a pretty intense nervous system side effect. We can see something similar in our H2 receptor antagonists. And so we want to make sure that we are not giving these if we're worried about central nervous system side effects. So, drowsiness, confusion. All right. In our older population, it doesn't mean we can't use these, but we need to use more precautions if we're prescribing something like famotidine in an elderly patient because they can have more central nervous system effects, just like a Benadryl. Okay. Think of it similarly. These guys work in the other histamine receptors that are, specifically in the stomach, but we know they can have a little bit of that effect in the brain as well. All right, next up, we have PPIs. I like omeprazole, pantoprazole, lansoprazole. If you notice, they all in that azole ending, and that is how I always want to alert students to really, really focus on learning generic names of medications because it gives you the clue of to what class you're working with. Okay, so when you're studying, rather than memorizing, even though they're easier to pronounce, typically, the brand names are easier to pronounce. I really want you to work on memorizing the different endings and the class of drug that they are, because when you're moving forward into your boards exam, that's an important kind of clue into what it is you're getting. All right, so PPIs really, really effective. They inhibit, and this is an irreversible um, uh, connection to the proton pump. Okay. So once it's connected, it's not coming back. They have to reproduce a proton pump in order to reproduce the acid. But it reverses, it attaches to a proton pump and inhibits the production of gastric acid and really, really reduces the amount of gastric acid production in the stomach, which can promote any sort of healing to the tissue damage that has occurred. So you have that esophageal damage from acid reflexing back into the esophagus. A PPI is going to reduce our pH significantly in the stomach and help heal any damage that has been done. We use this also in ulcers, which we'll talk about in just a moment, but this is a really important thing to understand and remember that if we have damage that we're trying to heal, we need a PPI typically to get that healing under control or healing initiated and tissue regeneration. Okay, PPIs, all day relief. You usually can use it about once a day. So, in the morning before breakfast, I like to say, might take a little bit to get to its peak effect. Okay, so it has a little bit of effect those first few days, but we say about a week to 2 weeks to show its peak effect. And helping reduce stomach acid. We know that these guys, long-term use can be a little bit concerning around vitamin D because it blocks absorption of vitamin D. So we could, or sorry, vitamin B12, excuse me, vitamin B12 deficiency, which then can in turn lead to some osteoporosis. So we think about PPIs, long-term use, not necessarily good, but again, this is a benefit risk analysis that we have to use depending on what's going on. And is if we can't modify, we can't make any changes. We do see people that are on these kind of long term. With the PPIs, I'm going to say I never discontinue them overnight. There is a phenomenon called rebound acid reflux when we stop these things abruptly. So I do a slow, slow taper, no taper on just kind of like when you're tapering an SSRI or something. going slow and really letting the symptoms guide your taper is going to be really important to coming off of these things successfully without your patient being absolutely miserable. So, a slow taper, I typically take about at least a month to come off of them, sometimes 2 months. And then I can use an H2 blocker in between to kind of cover any breakthrough acid reflux as we're tapering off a PPI at the end of a treatment or something. All right, when do we refer out? If we have done all of our interventions, if we have done lifestyle changes, we've considered an H2 blocker or the PPI, and we still can't get this under control, it's best that we get a little bit of help from our gastroenterologist, okay? They might do something like an EGD. They can go ahead and do niacin fundoplication, which is actually just tightening up that lower esophageal sphincter, which is pretty permanent. And it really reinforces it and it stops that reflux for good. And then bariatric surgery if applicable. All right, let's um, get out our phones again, and you can answer this question in the Slido. Oh, sorry. Let me just go here. Okay, so you are a nurse practitioner prescribing medication for a 77-year-old patient with gastro reflux disease. Which of the following medications would be the best choice for your first line therapy? Famotidine, okay. What else? Let's hear some other thoughts here. All right, we have Pepto-Bismol, calcium carbonate, Tums, lansoprazole, that's PPI. So famotidine is our H2 blocker. Lansoprazole is our PPI. Nobody's saying Pepto, nobody's saying Tums. Anybody else want to participate with this? All right, 75% of you are saying famotidine, and that is um let's just go into really quickly why I wouldn't choose the famotidine. It's not necessarily wrong, and you will see this in practice, okay? But remember, when we're using the H2 blocker, what did we say about the H2 blocker in the central nervous system and the precautions around using H2 blockers in elderly people? Because of that possible kind of central nervous system confusion, delirium, stuff like that, we don't necessarily want that to be our first line. Again, it's a never, like, never, never would I not, like never would I not use it, but with extreme precautions. All right. When we have an elderly patient, we're going to be a little bit more aggressive with treating GERD because we are concerned about possible risks of complications from esophagitis. Okay. I think about esophageal sphincters. I think of like Barrett's esophagus leading to some sort of a cancer, something like that. So I am going to treat this patient a little bit more aggressively than I would maybe say a younger person who we can really talk through lifestyle changes, etc. Okay. Tums not necessarily strong enough. Okay. If they're coming to you, we could use this for breakthrough, but this is not a first line treatment if it's severe in an elderly patient. The salicylates can cause severe constipation, which we're already a little bit concerned about in our elderly folks. As things kind of start slowing down, constipation can get very, very painful very quickly and lead to an obstruction faster than in a younger patient. So choice D, the proton pump inhibitor, the lansoprazole, even though long-term use does have risks, we are going to use a short term to try to get this under control and figure out what is causing it, okay? In that elderly patient. Most important takeaway there is just remembering those H2 blockers can have central nervous symptom effects in our old and especially in our older folks. All right, peptic ulcer disease. We think of peptic ulcer disease and oftentimes confuse it with GERD. They do share a common factor, which is that gastric acid. However, GERD really involves reflux of acid into the esophagus, where PUD or peptic ulcer disease, we think of gastric acid or pepsin eroding protective mucosal lining. So, like more severe, right? we have now caused tissue damage in either the stomach or the small intestine. So we have gastric ulcers or duodenal ulcers. Okay. We can get ulcerations in the esophagus as well. A little bit less common. We see them mostly in the stomach and in the duodenum. All right. H. pylori is the most common bacteria that's responsible for peptic ulcers, and it really works by increasing the risk of um, the acid production in the stomach and kind of interrupts, and we have an infiltration of bacteria overproducing acid and deconstructing some of our protective lining. Okay. We also think of NSAID use. Do you have osteoarthritis and you're taking a ton of ibuprofen? Not good for your kidneys and terrible for your stomach and increases the risk of a GI bleed for sure. So make sure if you're ever prescribing NSAIDs for, more than a few days, that you consider protecting the gastric lining with something like a PPI. What does your alcohol consumption look like? Are you drinking on a daily basis? Are you drinking a lot in a small period of time? That binge drinking, all of those things are going to increase our risk. And then also a family history. So, some of the questions that we want to be asking our patients. Okay, so the symptoms of our peptic ulcer disease really do vary depending on the location of the ulcer. When we have a duodenal ulcer, those ulcerations in the small intestine, we typically see something like a burning, gnawing pain, and that oftentimes becomes into between the breastbone and your navel or your umbilicus. Sorry, so that epigastric area. We think of it improving after eating or taking an antacid. When we think on the flip side, a gastric ulcer or a stomach ulcer, these guys tend to worsen when we eat, and that really causes it. And then we have this intensified pain about 2 to 3 hours after the meal. Both of these ulcers may present with kind of that dyspeptic symptoms such as nausea, bloating, feeling full, and weight loss, which would be kind of your red flag. If you're getting such severe um, ulcerations that you're no longer eating and now you're losing weight, this is a red flag to me. We also look out for things like bloody stool, some really, really foul smelling stools that might be dark in color would suggest a bleed in the upper GI tract. Vomiting blood, right? Not good. Severe abdominal pain could indicate a perforation or a bleed. These are serious complications that we don't want to miss. Okay. So if you see these red flags, please don't try to treat them in the primary care. Needs immediate evaluation. Okay, so we talked a little bit about GERD not having a ton of physical exam findings. So the patient comes in, they have this history, we're not able to reproduce anything. Maybe their epigastric area is a little bit tender, but not typically too bad. And oftentimes, just pretty asymptom or a doesn't give us a lot on physical exam with that GERD. However, if somebody has an ulcer, we're going to see some abdominal pain. We're going to for sure have a little bit of epigastric tenderness. When we are palpating them, they're not going to feel good. Okay. And then again, signs for a perforated ulcer, intense epigastric pain, tachycardia, abdominal rigidity, that guarding, that inability, that those abdominal muscles are engaged to keep you from touching what hurts or what is in danger. Okay, so that's how I think about that. When we think of abdominal rigidity, the body is doing everything in its power to really protect the patient. All right, these things, again, immediate evaluation in an emergency care. So go ahead, don't hang out with these patients too long. If you have a suspicion for a GI bleed, we need to get them up to emergent care, excuse me. For the treatment we have of PUD, we really have three goals that I like to think about. We want to alleviate the symptoms, we want to promote healing, and we want to prevent complications. Okay, that is our goal. How do we achieve that? So if PUD was caused from something like, again, the ibuprofen or a high dose of steroids, could we discontinue those as the first line to prevent more damage from occurring? Always Think about it. And sometimes we cannot discontinue medications because they have a benefit that's outweighing this risk. So what do we have to do to modify for this patient? And again, that oftentimes looks like a PPI. All right. With H. pylori treatment, we have triple and quadruple therapy. I'm sure you're very familiar with both of these, but what I like to tell everybody is quadruple therapy currently is what the guidelines are now recommending from gastroenterology. And that is a fairly recent change. So I don't know if you're learning that in school yet, but quadruple therapy is first line. All right, so what is quadruple therapy? Quadruple therapy is triple therapy plus the bismuth salt, okay? And they use a little bit of different antibiotic choices. So you can see here, both are going to have two antibiotics and a PPI. Just remember that. I like the acronyms. Treat my belly pain for quadruple therapy. You can write that down. Treat my belly pain. P for tetracycline. M, metronidazole. Belly pain is the bismuth salt. The B in pain is PPI, which we have in both, right? Then we move on to the triple therapy. We have a PPI. I like pack that ulcer. So we have a PPI, amoxicillin, and clarithromycin. So two antibiotics, one PPI in both, and bismuth salt. All right. So how do we know this is a pretty intense treatment? Folks are going to be on antibiotics for about 2 weeks, and that's a lot of antibiotic. So it's possible that you're going to see things like C. diff after this treatment. So just be aware of some of the complications that can arise from such an intense antibiotic therapy. What can we do to prevent that? I am kind of a believer in probiotics. Um, we are learning more and more about the microbiome, and we know that heavy antibiotic use, although indicated in this situation, right, can lead to other complications. So making sure we're just replenishing. If you like a probiotic, great. If not, can you eat more fermented foods, yogurt, stuff like that, to try to increase the good, healthy, normal flora bacteria that our digestive system relies on to maintain digestion and healthy digestion, but keeping that balance of healthy, good bacteria and bad bacteria to avoid something like a C. diff infection. All right, how do we gauge success? When we're testing for H. pylori, we cannot do a urea breath test if the patient has been on a PPI. And the reason being is that a PPI is going to give you a false negative. Okay, so if somebody comes to you, you're suspicious of an H. pylori treatment, you are sorry, of an H. pylori infection, and you want to prove that, you're going to get a test done. We can do the urea test and also stool test. The serum one, not great. And so those two, I think the breath test is kind of the top gold standard when we're considering for H. pylori testing, but they cannot have been on a PPI. H2 blockers, okay, they could be on a famotidine. Go ahead, switch them over as quick as possible. I did talk about that taper, but if we're trying to figure out what's going on, we need to get there a little bit quicker. Then we might be more aggressive with that taper and get them over to the H2 blocker so we can test for H. pylori. When we finish treatment, okay, say we get through their taper of the PPI, we do the breath test, they're positive. Now we choose our quadruple therapy as the first line treatment, and we're going to continue that PPI for about 4 weeks with the quadruple therapy. The reason that the antibiotics are 2 weeks and that PPI is a minimum of 4 weeks is because it's going to continue to help heal. We killed the bacteria, we've gotten rid of the bacteria, but now we need to heal that mucosal lining where we had the ulceration to begin with, right? So we're going to keep that acid level low, let the stomach or the duodenum heal back up, and then we're going to decrease the PPI over time, again, about a month, maybe 6 weeks of a taper to not get that rebound acid reflux. Go ahead, possibly use something like the H2 blocker for any sort of breakthrough pain. And then once we have been off of the PPI, for a total of at least 2 weeks, we can get a test of cure. We can ensure that we got rid of the H. pylori infection. Okay. Really important that there's that at minimum of 2 weeks if we're doing the breath test. Now, we can also diagnose H. pylori via biopsy. So, if perhaps you sent this patient to the GI and they had an EGD done because a scope performed because of concern of significant symptoms in that scope, likely they're going to go ahead and do a biopsy and they can test for H. pylori despite the use of PPIs and still get a positive result and go through treatment that way. All right. If we did not cure, we did the quadruple therapy. Our patients were very, very good about taking all of their antibiotics despite how difficult it is and how hard it can be on you. They do everything great. We do the PP or the H. pylori test after we discontinue for at least 2 weeks. This, I'm going to say this is about 10 to 12 weeks after we started therapy, oftentimes with a lot of my patients. Rarely do I see it positive still. Usually we're very, very effective with that quadruple therapy at getting rid of the infection. However, if it's still positive after a successful treatment with that quadruple therapy, that would be an indication to refer to GI. Okay, let's do another practice question, guys. Um, let me get over here. All right, we have a patient who reports being hospitalized for a perforated peptic ulcer. Oof, not good. Did not come in soon enough. All right, he reports frequent use of over-the-counter pain medications for osteoarthritis in his right knee. What pain medication may cause the GI perforation? First person said ibuprofen. What else? Capsaicin, topical lidocaine, acetaminophen. What are those medications? How are they processed? How are they applied? Do they cause gastric ulcers or increase our risk for perforation? Everybody said ibuprofen. You were listening. Amazing, you guys. You're doing so, so good. Yes, it is ibuprofen, NSAIDs. Very, very important. If we have to use an NSAID for the treatment of an inflammatory condition, we need to protect the gastric lining. Go ahead and prescribe an omeprazole that they take daily along with that. Same if you're on steroids, okay? Capsaicin, that is a topical. Obviously, topical lidocaine is a topical, and acetaminophen, no gastral effects here. We think about the liver, it's processed through the liver, but not so much. Okay, just a little plug here. We have covered a lot of information. If there's anything that we're going over, you're struggling with the content, remember you can rewatch our lecture today on these platforms through our Facebook group. You can also get more in depth. Okay, we're saying surface level today. If you want more in depth knowledge of this, get those on demand videos. Get the SurePass. We have this stuff. We're here for you. Don't let today's lecture overwhelm you. This is the stuff that we have to help you be successful and join the practice because we desperately need good nurse practitioners. So invest in your education, invest in your board prep. It is so, so important. All right. Moving on, acute GI conditions, signs of IBS, IBD, and we may or may not get to hepatitis today. We cover that in infectious disease. Okay, so gastroenteritis, commonly known as the stomach flu. This has been in the news so much lately. Norovirus, I don't know if you've been affected, but if you have norovirus, it's pretty hard not to know. I'll never forget. I was going to my kids went to a Super Bowl party. I was an RN working on a labor and delivery floor, so I missed the party. But my then 2-year-old and infant went to the Super Bowl party with my husband, and my friend, who's also a nurse, should have canceled the party. She didn't. Anyways, ended up spreading norovirus to like 17 people. And I was taking my kiddo to the zoo. It was like Tuesday, right after Super Bowl was on Sunday. This was a Tuesday, so the timing's perfect. I'm tying his shoe and he just throws up all over me. All right, that was it. We all got it. It went through the whole family, even my daughter, who I think at the time was like 9 months old. Just something really terrible, super contagious. You have to come into contact with the virus. So we think of gastroenteritis on on a viral level, which is that norovirus 90%, and they're working on a vaccine for this. So if the vaccine comes around, I highly suggest getting it because this can really wipe you out. Bacterial infections, we think mostly of food-borne stuff. Again, it can come in water forms as well. And then protozoal, we mostly think of those guys coming through contaminated water. I think of people who have been traveling. I think of folks who have been camping. Maybe they have some animal they're getting their water from a creek, and up creek some animal decided to use the bathroom in their drinking water, and they didn't necessarily clean or filter that water good enough, and that's how we get those infections. Okay, again, the viral, highly contagious. We also think of rotavirus, which we now have a vaccine for. It's that oral vaccine that they give in young kids. And what we think about when we think of this viral infection, I think of abdominal pain. Wow, you have some cramps, watery diarrhea, and vomiting coming out of both ends at the same time. Pretty intense, but typically short-lived. Bacterial infections, again, we think of this from undercooked meats or poor hygiene. Um, we think of pathogens such as Salmonella, Shigella, E. coli. C. diff can be one of these. That's a bacterial infection as well. We think of more bloody diarrhea, fever, more generalized malaise, vomiting, abdominal pain, really bad cramping. And then with this protozoal gastroenteritis, I think of Giardia, again, camping or like being somewhere remote or into a new country where, you just can get some water that doesn't necessarily have the same kind of hygiene standards that we have. What we see with patients with this is diarrhea, vomiting, abdominal cramping, malaise. And with this, I think of sulfur. With Giardia specifically, the way that bacteria presents, sulfur smelling gas can be very common in that. Okay, so to diagnose and treat, we really start with a detailed history. We ask about recent travel, food intake, exposure to sick individuals. Were you at a Super Bowl party? All of those things we want to know because, and does anybody around you also have similar symptoms? Because oftentimes that will give us a little bit of a cue. We think about symptom onset, duration, severity, frequency. How much stool are you passing? How frequent are your bowel habits or bowel movements, right? More than 6 a day, we start to get a little worried about some electrolyte imbalances. We think of dehydration. How much are you vomiting? What does it look like? Okay, all of those things are going to really help us in determining, is this viral, is this bacterial, and what should I do about it as a clinician? Obviously, we can do stool samples. We can test and we can find these bacteria that are causing it or these protozoas that are causing the infection. And it's not, nobody's going to, um, you know, fault you for getting that. I think it's a safe way to go ahead and do it. But again, let the history and the questions and the symptoms and all of that guide what you're going to do as far as lab testing goes on this person. All right, we're also going to conduct a physical exam, right? We're going to look for signs of dehydration. We're going to look inside the mouth. Okay, I feel like we learn a lot about skin turgor. We learn about heart rate going up, blood pressure going down when we think of somebody who's in a dehydrated state. But typically, especially in your kiddos, looking inside, are they producing saliva? Their lips may be dry. If they live in Colorado, their lips may be dry all winter long, but looking inside their oral cavity can be a very good cue as to their hydration status. Most of the time, we think of these cases as being self-limiting. What does that mean? We can use supportive care for these folks. If we have more severe symptoms, if their skin turgor is terrible, and it stays tented for a long time, if they have poor capillary refill, they're likely at an advanced stage of dehydration, and you should get them a higher level of care right away if you're treating them in a primary care setting. Probably need to get some rehydration via intravenous if they can't keep things down. All right, abdominal tenderness, guarding masses, anything like that. we're not gonna do a self-limiting approach for this, right? I love oral rehydration solutions. You can actually just make them at home, and there's recipes online. I did a lot of work down in Peru in the Amazon, and we just talked a lot about how can we create an oral rehydration for something like a viral infection for a person instead of having to go out and buy stuff. So Pedialyte is fine. However, you can make this at home. It's salt, sugar, and then like some sort of juice mixed in. So you can even like blend up a banana, something like that to get some of those electrolytes. And what you're trying to do is replenish the electrolytes. And then we talk about that brat diet, just something really, anything that they can tolerate, anything that they want to eat. Typically, we're going to let them eat or drink. Okay. My grandma used to give me 7 Up. I've heard people do Coca-Cola, stuff like that. If the kiddo or if that feels good, tastes good, I think it's okay in the short term. Obviously, I'm not sitting here saying drink lots of soda. Never a good idea. Okay. If we think that there's a bacterial infection or a protozoal infection, now we start thinking about antibiotics or antifungal. The protozoals, the flagyl, metronidazole, stuff like that, especially going forward. So traveler's diarrhea, we think of Cipro as a pretty good thing. Also, a Z-Pak can help with that. I always check up to date when I'm prescribing antibiotics, no matter what I'm prescribing them for, just to make sure, and checking to see any resistance in your area is always a good idea to kind of get it. And just remember, I don't treat traveler's diarrhea often enough where I live here in Colorado to be able to like fully pull out, okay, from memory what this is. So I just look it up on up to date to get the most recent things, make sure we don't have any allergies or something like that. We can consider something like loperamide to get onto an airplane. If you're needing to travel to get home or you have to get to this meeting, you can go ahead and use something. But typically, I like to just allow patients to move through this. And you definitely, if there's bloody diarrhea or something like that, we will not stop it using an anti-diarrheal like a loperamide or Imodium. Only, worst case scenario. And if we're worried about dehydration, that might um, kind of help control and slow down some of it. But typically, this just has to run its course. Okay. We are coming up on the hour, you guys, and I want to invite you to stay a little bit longer. I'm going to keep talking here for a little bit to kind of go through a few of these other things that I want to go over. But if you need to leave, feel free to step out. You will get your hour of CE or your contact hours for attending up to this point. But please, if you're eating lunch or whatever, and you have the time, stay with me because we have a couple more cool things to talk about. Okay, the abdominal exam here that I really like is called the Carnot's test. This is just a little tip trick in the primary care setting that I use, and I really like it. And it's not a fall safe, right? This isn't like a diagnostic tool. Again, helpful in deducting what might be happening with our patient, but not a for sure. So this is just one more kind of clue into our problem solving puzzle for abdominal pain. Okay, when we're switching gears here, we think about what is going on. We talked about how we perform our test, our abdominal exam, and the order in which we have to. This guy here is really, really useful in differentiating between abdominal wall pain and deep visceral pain. Okay. When I think of visceral pain, I am thinking of the liver, the gallbladder, the intestines, the stomach itself, right? We're thinking of all the appendix. We're thinking of the organs when we say visceral pain, pain originating from an organ or the capsulation of the organ where the nerves are actually innervating it. Okay, so what do we do? How do we perform this? Sorry, the organ pain versus the abdominal wall pain. Did your patient just do a bunch of sit-ups and now they have really intense pain? I'm going to tell you, my daughter, she went to gymnastics and hadn't been in like restarted gymnastics after taking a little break over the holidays. Went back to gymnastics. They had like a ton of ab kind of workout stuff that they were doing. The next morning, she told me, my stomach hurts so bad. So bad. I don't think I can go to school. Like I can't even get out of bed. And as a nurse practitioner, thinking, okay, is this acute abdomen? Do I have an appy or something going on here? And she had kind of like this real concern. And so I start thinking, what's going on? And so then I do perform my little abdominal exam on her and a Carnit's test. And what we determined is it's abdominal wall pain. So how do we determine that? We determine that by asking them to, identify the precise location of their pain. Okay. And then we put our hands on that precise location of the pain and we ask them to go ahead and engage their abdominal wall. What does that mean? Do a little bit of a sit up while I'm pushing on where it hurts. Okay. What happens physiologically when somebody's doing a sit up? Their abdominal wall engages. Okay. Now we have a protective barrier between my fingers and an organ that has inflammation potentially happening in it, right? So when we now have the abdominal wall engaged and I'm pushing hard on that, if that pain gets better when that organ is protected, we think that the pain originates from something visceral. Okay. However, if I'm pushing on an abdominal wall that's engaged and it makes that muscle feel even worse, we think it's coming from the muscle itself. So that's what I like to use as just another clue. Okay. This is non diagnostic, and sometimes it doesn't work. Sometimes the patient says, I don't know, doesn't feel any different. And therefore, you get this like, okay, if it doesn't feel any different, how do I think through this? Maybe it's abdominal wall, but can I rule out something bad, worse going on? Again, it's the full clinical picture we got to be looking at and thinking about. All right. Any questions with that? Okay, let's get on to some of our really common um, things that we see when we're thinking about starting to include that abdominal wall test, the Carnet. So I use it in all of these cases. Okay, this can be just one thing that helps. Cholecystitis. What is cholecystitis? It is inflammation of the gallbladder. It's often caused by a blockage, so a stone in that cystic duct. Okay, we think of risk factors of this. So, we can see it in anybody. However, we have more common presentations in women who are over 40, anybody who is obese or pregnant, if somebody has a history of diabetes or rapid weight loss. So, all of our folks, we have 1 in 8 Americans who are on a GLP-1 right now. They're losing weight. They may present with something like a gallstone because of that rapid weight loss. We don't typically want patients losing weight too quickly because of this risk. All right, so what do they kind of look like? They come into your clinic, they have right upper quadrant pain, bloating, feels worse after they eat greasy or spicy foods. They might have a little bit of nausea, vomiting, gas. They might have this radiation of pain right to their right shoulder. Why is that? Because of the way that they're innervated. So you have that referred pain to the scapula on that right side. And then more serious symptoms would include something like jaundice, clay-colored stool, fevers, chills, stuff like that would indicate that something that we need to be a little bit more proactive. We do the Murphy's sign to test for this. So we do a deep palpation while the patient inhales. We're going to deeply palpate under that right rib. And if they kind of stop when you're touching, when you hit that, again, we are now touching an inflamed gallbladder and it has that encapsulation that has all the nerve endings in there. It's going to hurt. And that tells us that we should be concerned. Again, non diagnostic, but we should start thinking about a cholecystitis here. We can do some blood tests in addition. So we could check an elevated, a white count, and if it's elevated, that would help us clue things in. This is more of like an urgent care emergency room kind of workup that we're doing. This is hard to do in a primary care office, but this is what they would likely do. You can do some anticipatory guidance. If you do the Murphys, you find that it's positive and you send them because you're really worried that they have something like this going on, you send them over. This isn't some anticipatory guidance you could provide that they're going to do some blood tests. They'll likely do a scan of some sort, an ultrasound or a CT scan. Okay, to confirm the diagnosis, they're going to assess your gallbladder function through these things, looking for any sort of obstruction and rule out something like a stone there. So, how do they treat it? Well, depending on what they find, they may do just bile acid medications like ursodiol. They might just say, let's change your diet to something low fat. Um, they can break up the waves with that extracorporeal shockwave lithotripsy. They also do those in the kidneys to kind of break up any stones. And they might actually need to remove the gallbladder. Okay, pretty common that they have to go that route. I would say, I had a friend just, gosh, a month ago, came back from Costa Rica, thought she had some sort of infection. Turns out she had, cholecystitis, and they had to do an emergency cholecystectomy and get it out because of her presentation. So I'm gonna just move beyond that question, sorry, just to, in the sake of time here, and talk a little bit about pancreatitis. So pancreatitis, again, another common thing, and what we think about here is inflammation of the pancreas. This can present similarly to that cholecystitis, but we think of the risk factors a little bit differently here. So when I think of a pancreatitis, I'm really asking about alcohol consumption. It's a very common cause. Somebody goes on a binge, several days, maybe over a weekend, maybe over 5 days, have a high consumption of alcohol, and now they present with something like a colon sign or the Gray Turner sign, or just generalized epigastric pain, nausea, vomiting. They look not great. They don't feel great. They're throwing up, really can't eat or drink much. Um, and you ask him about alcohol, and yeah, well, I did go to, um, I had a hard Friday at work, and I drank all weekend long. This could come up. The other thing that can cause this is high triglycerides. Okay, so if somebody has those triglycerides over 500, they're at an increased risk of pancreatitis. We need to work to get those triglycerides down quickly. We need to make sure we can use things like omega-3 fatty acids. Um, Not long term, but some fish oil supplements can help lower those triglycerides. We have other medications that we can also prescribe to get those triglycerides down to reduce the risk factor of a pancreatitis. But if we see somebody who unfortunately we didn't catch in time and they do have a full-blown pancreatitis type presentation, we're going to send them out for further evaluation. All right. So like I said, we could see some sharp upper left quadrant or epigastric pain, especially after eating or drinking. Oftentimes, these folks are going to have nausea and vomiting as well. Um, I have not personally seen a colon or Gray Turner sign. I have seen folks in early pancreatitis, and I sent them to the emergency department. Um, but any sort of abdominal bruising, ever, 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 not normal unless we have trauma that caused it. We'll go ahead and check serum lipase levels. We would typically see them 2 to 3 times the upper limit of normal, and that would give us a diagnosis of pancreatitis. We could see an elevated BUN. Hematocrit levels might be high as well, but imaging to diagnose would be something like a CT or an MRI that they would often get at that point. And the treatment is pretty interesting. We just resuscitate with fluids. So LLR solution is really what's given, and then pain management. If we think there's some gallstones or something like that, we might also need something like a cholecystectomy if they're co-occurring type presentation. And then, like I said, with the triglycerides, if they're elevated, they may use something like an insulin drip to try to break down those triglycerides a little while the patient's in an inpatient setting. Okay, diverticulitis. This guy is so common. And the treatment has really changed. We used to do everybody on antibiotics and inpatient for this, but we have learned over the course of the last few years that maybe we don't necessarily always need antibiotics. Um, so just something on the horizon that's coming out. I think it is currently in the guidelines. Is it reflected in the board's exam? Not sure yet. But what is it? So diverticulitis, inflammation of the colon's tiny pouches. No longer do we think it's caused by seeds, nuts, or popcorn like we once thought. We really think that like constipation, low fiber diets, getting a backup of stool into those pouches is probably what's causing those little pouches to become inflamed. But the concern is a perforation of that pouch. Okay, so we want to intervene as soon as possible to prevent a perforation because if we have a perforation, we now have bowel contents that's leaking. Okay, here we go. Bowel contents leaking into our peritoneum cavity. Not a good situation. We think about sepsis, right? Okay. When somebody comes in, we talked about this, left lower quadrant pain. All right. I think of left lower quadrant pain. I think of constipation, diarrhea, but I'm always thinking of that colon. All right. Physical exam, we might have some guarding tenderness. We might be able to palpate a mass indicating some sort of an abscess that's formed, but typically they're going to come in either before that happens or they're going to look pretty darn bad if they have a perforation. The bowel sounds will likely be hypoactive. The bowel is trying to protect itself. It's slowing down because there's just not really responding. It knows that it's injured down further, so it just kind of slows things down. Um, but if we think that there's a perforation, we would look for signs of like shock, hypotension, tension, tachycardia, peritoneal signs, so that rebound, tenderness, guarding, rigidity, anything like that, that's going to the emergency room. Okay. Um, when we think of treatment, really we can diagnose it. If it's somebody that who's never presented previously, then we can go ahead and be a little bit more aggressive. That's an abdominal CT. If we're concerned about them being really at risk for perforation, then that's an ED, right? We're sending those guys to the ED. They're going to get a stat abdominal CT. However, can we manage this in the outpatient setting? Possibly, depending on how they present, right? How sick do they look? Um, but it's not out of the ordinary. If you can get an abdominal CT outpatient today, which is possible, and get their labs done today and have them go ahead and switch immediately to a liquid diet. Okay. And then we wait for all those things to come back, see how they do with that switch, potentially start an antibiotic. That's the question that we have, which we'll talk about in our case study. But that's kind of what we're looking for. Okay. Um, Sometimes if they're unstable, we're going to send them inpatient for IV antibiotics, outpatient plus or minus antibiotics, but definitely going to that clear fluid and immediate follow-up. So I see these guys, if I can get them in the next day, have them come back just to put eyes on them, get their blood pressure, get their vital signs, see how they're doing with this thing. I don't expect a huge improvement in 24 hours, but they should be getting a little bit better. And then every day, after that, maybe it's a phone call, definitely putting eyes on that patient within 5 days. Okay. Um, Again, that oral antibiotic outpatient is kind of going away. The first line recommendation, if we're not concerned for a complicated case, is just going to a clear liquid diet. But if we want to, nobody's going to fault you still today because it's still common to go ahead and prescribe something like Cipro or Bactrim, metronidazole for 7 to 10 days, along with that bowel rest and increase fluid intake. Again, if you're concerned at all, just send them to the emergency room. Okay, appendicitis. This is super, super common. So I think of a story, let's see here. A 10-year-old boy, wakes up and has some really, really bad pain in his belly button. It's not feeling good, has some fever, some nausea, just not feeling good. And as the day progresses, mom thinks, okay, or dad, I should say, our parents, let's just watch and see what happens. And as the day progresses, this pain gets more intense and moves down to that right lower quadrant. What we're thinking about is any pain that originates from the belly button and moves to that, and especially it seems to be common in younger males. We should be thinking about appendicitis. Appendicitis can occur in anybody, and it can present a little bit differently. However, that's our kind of the risk factor kind of folks that are at increased risk of this. But typically, nausea, vomiting, fever, fatigue, really going to be guarding and like not wanting to do anything, hard time walking, every step kind of hurts. And it's right in that area down there. Now it can refer because we know that the way that the nerves innervate, we can get some referred pain. So that's why some of our tests look a little bit different. But we don't want to miss it. And so we have McBurney's point. That's 2/3 of the way from the um, umbilicus, sorry, to that anterior superior iliac spine, the crest, right in that area, that right lower quadrant area is where we're going to find the McBurney's point. So tenderness to that exact spot. Any sort of guarding when you're trying to touch that, really trying to walk very, very cautiously because it hurts. Those are all signs or cues that something like an appendicitis might be occurring. All right. So some of these other things, we have the Bloomberg sign, the Rosvig sign, the Markle sign, the obturator sign, the SOAS sign. There's this one I like where you just have the patient, which one is it? The Markle test, where you have them just kind of go from their toes down to their heels. That's an easy one because you're not, and if that hurts or you see them walking very cautiously, then you know that there's a possibility of something like an appendicitis happening in that patient. And it's, again, just going to cue you into what your next steps are going to be as the provider. Um, I just go ahead and get a snapshot of this so that you can review these. I say practice on your family members or friends, so you feel really confident in doing these. Again, um, patients are going to have some guarding. If there's a true concern here, we need to differentiate, is that patient ticklish or are they guarding? And there's a rigidity occurring in the abdomen. And those things are very, very different, and you will know when you see it. All right. We have more questions here. I'm going to skip past those questions, and let's just talk very briefly about irritable bowel syndrome. So, irritable bowel syndrome, this is a common GI condition. The patient story I think about here is maybe one of you guys. No, females, younger, maybe college, lots of stress. Maybe they're high anxiety. Maybe they're like type A, trying to do really, really well in school. Those things tend to evoke some symptoms of an underlying IBS thing that's occurring. Okay. And I don't mean to like be like gender anything here. It's just that that's typically the common risk factors that we see. Just however, it can happen in both sexes regardless. Okay. What we think a little bit here is their symptoms. So we think of their symptoms, especially in relation to eating and stool characteristics. Okay. We always ask about our red flags indicating serious issues like bloody stools or weight loss. If somebody's having bloody stools or weight loss, it's not IBS. Okay. Something more significant is going on. All right. What we think about the Rome 4 criteria: recurrent abdominal pain at least once a week, along with two of the following. We have pain linked to defecation, stool frequency change, or stool change in appearance. All right, so the stool is happening more or less often. It looks different. So we might go from constipation, diarrhea, and back and forth. And then we really tailor our treatment depending on what we see. So the FODMAP diet is something that I oftentimes have conversations about. I'm ruling out anything more severe, right? When we're getting to irritable bowel syndrome, this is a little bit of a diagnosis of exclusion. So we have excluded other things, and so we can kind of land on this one. And then we can try things like a FODMAP diet. While we're getting a diagnosis, it doesn't hurt to start things like the FODMAP diet. And I don't say you have to stay on a FODMAP diet forever, but go ahead, look it up, do some reading, and see what those really, really common trigger foods are for folks with IBS. Go ahead, eliminate them all, and then every 2 weeks, add something back in. And if the trigger or the symptoms are triggered, then we know that that new item that you added back in likely isn't great for you. Um, Specifically, we think of wheat and dairy, some fruits, some vegetables, and it's very, very individualistic. We can consider some treatment. There are different treatments and medications that are prescribed. A lot of times, if I can't tend to get things under control with this type of early recommendations and they're very symptomatic, and in their workup, I've probably already sent them to GI because they're presenting in a non-characteristic way. And so maybe a colonoscopy or something like that is a good rule out diagnostic. Okay. IBD is going to look different than IBS in that we can actually go in with a scope and see damage occurring in the intestinal tract. We can get blood markers and we can see inflammation happening in the body, non-specific inflammation. So CRP, ESR, if we draw those labs, we're going to see in somebody with an inflammatory bowel disease that those inflammatory markers are high. Okay. We won't see that necessarily in somebody with IBS. Okay. So when we think of IBD, we think of Crohn's disease and we think of ulcerative colitis or UC. Crohn's disease is really characterized by strictures, inflammation, and skip lesions. It can occur anywhere in the GI tract. Okay, this is can be a very devastating disease if not maintained and put into a remissive state. So these are autoimmune diseases. We think our immune system is inappropriately attacking our GI system, and we see those fistulas, lesions, really severe weight loss, non-bloody diarrhea is going to be more of our key to Crohn's disease, weight loss, nausea. I had a patient when I was in nursing school. This was a long time ago at Seattle Children's, and she had lost a lot of weight. Um, Ended up needing a full bowel resection to take out the diseased part of her small intestine, but she had the skip lesions. She had some significant fistulas occurring, and her disease came on quickly and took a very quickly aggressive turning point. But with medications, they're going to get it under, they were able to get it under control. Ulcerative colitis, we think of really, really limited to the colon. Okay, it starts typically in the rectum and it's going to work its way up the colon. We think of bloody diarrhea, we think of mucus, we think of tenesmus. Tenesmus is that sensation that you didn't empty your bowel contents. So you had a bowel movement, but you have that continued like desire to keep pushing or straining because you get this sensation that it's not fully out, even if it is. Okay, we want to watch out for toxic megacolon, which is abdominal distension, fever, severe pain. Those things are something that we just really need to be on the lookout for because that is an emergency situation and we need surgical treatment immediately. Okay, we talked a little bit about that diagnosis. So colonoscopy, likely where they're going to actually get, or endoscopy where they'll get a biopsy, depending on what part of the colon they think is mostly affected. Again, we're going to see elevated inflammatory markers. We might come in with an initial bowel obstruction, could be like our first sign of something like ulcerative colitis. So we want to keep those things in the top. Like I said, our treatment, this is more at a higher specialty. So if you get into GI specialty, you'll probably be prescribing these types of medications if you have a patient with IBD. As a clinician working at primary care, you need to be comfortable with these. I may bridge somebody, but I don't typically jump right into these on my own. All right. And last but not least, we're just going to touch on hepatitis here. Just a really quick refresher. We do talk about this in our infectious disease a little bit more in depth, and it's on our on-demand videos. This is not meant to be like a full deep dive, but we have hepatitis A, hepatitis B, C, D, and E. All right. So when we think of hepatitis, we're thinking of inflammation in the liver, and there are several different types. Okay, we really, really want to think of the one that we can prevent, which is hepatitis B via um, vaccination. And if we prevent B, then we also are preventing D. Hepatitis E, very rare here in the United States. It's mostly seen in areas where there is more contaminated drinking water. We think of the spread really through like fecal oral transmission. When we think of contaminated fluid water often occurring in kind of those underdeveloped countries and lack of like sanitation facilities and so forth. B and C prefer to hang out really in the blood. We think of those as bodily fluids. Think of like things like unprotected sex, needle sticks, sharing needles, illicit substance use. Can increase this transmission from mom to baby. So that's why we always check mom for hepatitis B. During pregnancy because it will increase and then we will treat the infant differently as soon as it's born and to prevent that infection. But again, this stuff does hepatitis B and all of that super in depth and understanding, and it's an important topic to look into for your boards exams. So go ahead, click on our videos and watch a little bit more in depth about hepatitis B and how to interpret those labs. That is a very important exam question. All right, symptoms here can be pretty tricky. You might have a fever, malaise, myalgias, jaundice, skin jaundice of your skin or your sclera, so in your eyes, nausea, vomiting. You might have some changes in the color of your stool. Um, and like something like hepatitis C, it might be completely asymptomatic. In up to 80% of cases, we see this being asymptomatic. That's why we have this new screening recommendation from the CDC in all adults over 18 to have at least one screening in their lifetime, more if they have more risk factors, right? So if you have folks that do suffer from substance use disorder and they are commonly sharing needles or something like that, then we may want to go ahead and consider doing something else there. Okay. Um, oops. Sorry, my screen just went out here. Okay. Um, and then when we think about diagnosis and treating, again, we're thinking about history, recent travel, tattoos, piercing, a little less common as we have better sterile practices. But if you're, getting a tattoo in a less sterile environment, I would be cautious of that and asking. Incarceration can increase risk of drug use as well. So during physical exam, we're really looking for signs of jaundice, and it typically starts from the head down. And so you're going to be looking for that. You could see bruising of the skin. You can palpate the liver for enlargement, so hepatomegaly. We'll also do some blood tests looking for liver enzyme inflammation. So AST and ALT may be elevated. We might see clotting factors in advanced stages of disease that their clotting factors are actually going down. So when we are concerned, somebody has bruising all over, we think about the liver right away because they are really responsible for producing that kind of clotting cascade. Um, we'll confirm with the hepatitis panel specific antibody and antigen tests that you guys can look at those videos to go into. But again, I can't stress off, the importance of hepatitis B vaccination to prevent a very, very serious hepatitis that can lead to cancer in the liver. So something really important to talk with patients and parents about, especially as they're having children, that we do have this vaccination available and it does prevent some serious diseases and possibly hepatic cancers in the future. Hepatitis C, we now have a cure. So we can, offer that to our patients. That's something you could become an expert in your primary care clinic and actually go on and take on patients and do that. That's not something I have done. I actually refer out to gastroenterology for hepatitis C, just because it's not in my repertoire, but just like HIV or something like that, hepatitis C is something that if you're very interested in, you can learn about, become an expert, and go ahead and offer that in your clinic setting if it's a need. Okay, you guys, I had a really great case study, but it is now 12:30 and I have to wrap up because this is my allotted time. It has been such a pleasure. I hope you got something out of today's lecture. I'm again super excited to be able to offer that ANCC contact hours or continuing education hours for your certification. I recommend having just your like spreadsheet and keep track of it and put them all in the same folder every single time. So when it's time to recertify, you have evidence. Again, join us if you are getting ready for your exam. This service, I wish I had it when I was studying. It's so great. I'm really excited that we offer it. Really just makes you feel confident the day of. If you're passing that test, again, we have the SurePass method of studying, which includes making sure you're reviewing your content videos, okay, 25 to 50 questions a day, and then at least 4 exams, each one assessment exam every week for about 4 weeks. And once you get that sure pass, that high probability of pass rate on the meter, then you know you're ready to set for your exam. Okay, you guys have a wonderful rest of your day. Thank you so much. And I'll be back in 2 weeks talking about MSK. Again, we'll offer that credit hour. So please tune in. And there are other great colleagues that have stuff coming up. So just if you're not already, get on our email list so that you can get the links to the actual Zoom presentations. That is how you can get your contact hours for coming and spending your hour with us. Okay, take care, guys. Bye.